Hi, Mike. How are you? So,
Good.
I know we're running behind, and we apologize. I know sometimes the lectures are very good, and the cases take a little longer, but we're going to really try to stay on time, Mike. It's quite a complex case with heavy calcification, but we've already started to do some of the work, but we will finish the work online. So again, our team, Dr. Guja and Dr. Farhan here, Sardar Farhan, and we're going to go ahead and start. And I'm sorry, Dr. Bimmer is here as well. So we're going to go ahead, and Dr. Farhan, if you can present the case quickly.
Yeah. We have a male patient, 71-year-old. He has classical risk factors with hypertension, hyperlipidemia, and diabetes. Also important is he had a history of CVA without residual paresthesis, and he has hypothyroidism. His ABI on the most recent ABI on the right lower extremity was 0.64, and the left was 0.78 after a recent intervention about 8 weeks ago. And his ultrasound shows a long segment diseased SFA with stenosis estimated between 50 and 99%.
So Mike, this guy's a classic claudicant. He had an intervention of the left SFA. His ABI on the left was 0.54, and if you can show the angiogram, we're just going to play it. So all we did was, we did a balloon. Can you go to the angiogram? Great. So you can see the left SFA, which was treated, a very, very classic claudication. He has no residual from his what is it called, CVA. And once we opened his SFA right there with the supera, he did very well. ABIs are almost 0.8, and he's able to walk quite a bit on his left leg. However, his right leg we saved for us here because he has a classic popcorn calcification of his right SFA. As you'll see in the angiograms, he has diffuse eruptions, I'll call it, throughout the SFA. Proximal, he has some eruptions there. You can see there's luminal compromise. And then mid in the adductor canal, as well as distal, he also has significant eruptions and luminal compromise, albeit very eccentric in nature. Ivis, please. So we put a 7 French sheath up and over. We did bivalve Rudin. We crossed the wire, obviously very easily with this lesion. And really the challenge is treating it. Can you go to the intravascular ultrasound? So the intravascular ultrasound was done. And it'll play in a second. As you can see, can you show it? Oh, they're trying to switch it? Okay, I'll just talk for the sake of time. There was multiple severe stenotic calcified, eccentric calcification. There you go, it's going to come on any second now. Severe stenotic with eccentric calcification with luminal compromise throughout the SFA. So if you, I don't know why it's not showing for you, Mike.
You can directly put it on the screen.
Can you just put it on the screen?
There
it is, okay.
Perfect.
No, that's not it. No.
No. Can you just go onto the screen?
Oh, that's the veno.
No, that's the wrong room. That's the wrong room, guys.
Guys, switch to this room.
So I'm going to ask the panel, any of you want to comment? You obviously got a pretty good taste, I think, of that proximal SFA with lots of calcification, stalactites, and various kinds of lesions. Any thoughts immediately, or any advice for PK?
It's still the wrong room.
Well, I'm anxious to see the IVUS because, which we're seeing now. Clearly there's long segment disease, but not all of that may need to be treated. There's probably a couple focal areas that IVUS will really help identify as being a problem.
Brian, you can see the IVUS now, and you can see how the IVUS again shows severe eccentric calcification and severe luminal compromise on one side, and right there, as you can see, and it's throughout the whole SFA in popcorn-type eruptions. So you can see also, can you go to the cine angiogram? I want to show the angiogram.
Yeah, it's coming in.
And if you can see the cine angiogram, I just did a dry run now with this entire SFA with that. And I'm just going to go ahead and just inject some dye so you can see without DSA how bad the flow is and what you think. See? It's all the way down. So at this stage, this is kind of where we're at. And, we decided to treat this, obviously, because he's symptomatic. And I don't know what you would suggest, but we felt because of the eccentric nature of the obstruction and the calcification, the options would be two. One, sort of a Dr. Schneider approach, as I would say, crack and pave kind of thing, where you put the coverage stent in and then balloon angioplasty it. or the second is vessel prep, and then decide what to do, maybe possibly a supera. So here we went ahead and I've started doing the shockwave device, and I'm curious to see whether all of you would agree with that. So we're just going to start and treat this area with the shockwave. Go ahead. You know what to do.
PK, it's Sahil. Were you able to cross True Lumen? I think that obviously helps decide which options you might have.
Keep it pressed.
I think the shockwave device is a great technique, especially when you get
Increase the
deeply
volume,
subintimal and you might be wary of doing a debulking strategy. I think if you're True Lumen, you have more options available. So it looks like you were able to wire this clean.
Yeah, it was actually not that difficult to wire. It's just, as you can see, you have these large extrusions of calcium that are really, really difficult to treat. You know, this is our 5th application of the shockwave device. We're only planning on treating the distal because that's where we had the greatest gradient. And so what we did was here, we treated it now in this area. And the proximal, I don't know what we're going to do, but at this stage, we're going to go ahead, down please. We're going to go ahead, this is our 6th treatment, is it?
This is the 5th.
This is our 5th
We have
treatment.
one
We're going to
more.
do one more. Each shockwave balloon, as you know, is allowed to
6.
do up to 6 treatments. We initially go up to 2 atmospheres, press the button, and then it does this wonderful beeping thing, and sends out some shocks. I'm assuming. I'm teasing, but I think you know this is how you use it. Then we go ahead after a little while, and Dr. Guj will go up to 4 atmospheres, and then how long do you wait?
30 seconds.
30 seconds, and then go up to 4 atmospheres or 6 atmospheres,
6
right?
atmospheres.
So
and then with 30 pulses.
the images from Shockwave, because if you ever see the video of this thing in a gel, it really looks like it's a dramatic explosion.
there's a lot of,
But much of their trial in pad, I guess 1 and 2, really are these popcorn
Get us
lesions,
the
and they
Dorado
have very
first.
limited. They have no real embolic. I would think that they would have embolic events, but they don't. This is really disruptive technology, no pun intended. I think this is going to be a game changer.
So it's interesting, you know, I think Brian's initial comments were very appropriate. You really don't need to treat this entire diffuse
Right.
disease. You really want to be focal. And for those of you who perhaps don't have IVUS, you know, you could put an 014 wire down and just a catheter and bring back and check and see where the largest gradient is. That's sort of the poor man's way of trying to assess which is the most hemodynamically significant lesion and then start there. I think that the tendency is that you want to look at this and say, oh, there's a lesion there, and you end up with that oculostenotic reflex that you really want to avoid. Otherwise, the next thing you know, you're going to end up with a full metal jacket.
So Mike, that's exactly what we did. And I want you to, you know, I learned from you, as you know, you taught me, and this particular lesion, we looked at the gradient, Mike. We pulled it back. The heaviest gradient that we had with a pressure wire was mid-distal. So he's a claudicant, and you know, treating the whole SFA, I don't know if we'd benefit him. So here we decided to just shockwave this area, and now we're going up with the Dorado. And so there is going to be a lot of pain at this stage. We have to crack this lesion. And this is what I meant by, you know, either you crack and pave or does the shockwave help? And I guess this is going to be the proof in the pudding. So right now we're at 4 atmospheres. Patient is already having some discomfort. We're going to keep trying to go up here. Would anybody do any sort of atherectomy other than a shockwave in this state, in this case?
Adventitial catch.
A little more?
I mean, I certainly wouldn't go to atherectomy as a first line. I think that there's a lot of diffuse disease. You're potentially debulking a large area. And I think this is a case in which you're really at risk for atheromatous embolization distally. Clearly, you'd need distal protection, and you may very well overwhelm that with the amount of calcific disease that's present. Any other comments? People have other thoughts?
You know, I think that atherectomy could be helpful for that focal lesion that's not opening up there.
10, 12,
Excisional atherectomy directed there might be helpful, but I agree with you, if you're going to try to treat the entire thing as a standalone without a scaffold, you'll be doing a lot of atherectomy and generating a lot of emboli. But it's possible that focal areas like that will open up easier with atherectomy than what he's doing. But on the other hand, a focal balloon might do it as well.
So when you see that balloon expansion, Mike,
you
this
go
was
up on
the
the
area of the greatest gradient right at the area. Now we're at Dr. Guja's at 12 atmospheres. The question is, do we go to the point of possibly rupturing this? Is this enough expansion to get a supera in, or should we put a covered stent in and just rupture rupture this vessel?
My fear, PK, is that this is a Dorado, you said, right?
Yep.
And so, Kevlar is not expanding there, so even if you put the Viabond down there, it may not crack
Yeah.
well. I think you need to do something else for that kind of eccentric plaque. Now, whether or not you do directional, rotational for that, or even orbital, that may change the compliance in that one area.
What's your balloon size and how many atmospheres are
This
at
is
now?
a 6.0 Dorado at 14 atmospheres. So the question here is, do we rupture it outward and then go ahead and put a covered stent across it? Because I'm sure if I go up a little bit further, this is going to rupture. We can go way up on this balloon, as we all know, and it's expanded quite nicely above. And now you're getting like maybe a 4 millimeter lumen at that area. So that's my only question.
You could do it stepwise. Sometimes I'll go down to a 520 balloon, hit it with that till I get it to expand, and then take a look at it, see if I've ruptured the artery
All
itself.
right, guys, give us a 520 and a 620
Would anybody use
Dorado?
a scoring balloon or any other technology here? I think focal atherectomy is still on the table. You don't necessarily have, unless you take a picture and you see a terrible flow limiting dissection, you still have that option also.
Dr. Parikh, I'm just curious. When you look at the IVUS, can you play the IVUS one more time? The IVUS shows that it's all outward calcium pushing in. And I know in coronaries we generate some heat with the rotablation and we're able to modify the plaque. But is that applicable to what we do here in the periphery as well? I'm just going to take a picture. Inject. That's okay, inject.
Hey, Darren, do you want to come down here and talk a little bit about your experience with some of the covered stents, in a situation like this? How aggressive should you be?
Is this
Have you had
the prior
both
run?
good or bad
PK?
experiences with that?
This is post PTA.
This IVUS run is post PTA.
Oh, this IVUS is pre, I'm sorry.
Okay.
Now I'm going to do post for you, IVUS. How much time do I have?
8 minutes.
Okay. I'm just going to do a quick IVUS, and I'm going to do what Brian or Lawrence suggested, which is go up with a shorter Dorado and try to be more focal. But I'm still curious. Nobody's answered about that thought about this adventitial type calcium, whether it helps or not in this situation to do an atherectomy.
I think if it's intraluminal, you can say probably unequivocally that will help. If it's a periadventitial, it may not help. But the act of using an atherectome of some kind may allow you to fracture the calcium enough to get.
So here's the
lumen gain.
IVUS.
Regardless of where it lives, whether it's adventitial or medial, I think that at this point it's compressing that lumen. So you have to cut towards it, and maybe directional would be
That's
the right
the spot,
choice.
Lawrence.
Yeah. I would think that, and you have a pretty good bullet that you can see on fluoro, so, directional control may be the right answer. The question is, how much you've disrupted it and what kind of debris you'll create. Who knows?
You don't have a lot of dissection, so you still have options.
Yeah.
No, I just wanted to ask the panel. You guys don't think this is a pretty good lumen to put a 5.5 supera? You guys don't think 5.5 supera will expand?
Yeah, how about stacking the supera,
Yeah.
Lawrence and Brian?
6 or 20.
So Darren, I want you to address the issue with covered stent. Would you use a covered stent in this situation? Are you willing to do that without first ballooning this to a larger luminal diameter? Do you think that that's essential for your covered stent to be successful, or can you go in with a covered stent and then more aggressively balloon dilate?
Yeah, so I think that, I think we're hitting on all the important points. I think the whole point is this real bulky eccentric calcification that you're either going to have to remove it or you're going to have to completely displace it. And sometimes displacing it may mean that you may end up rupturing the vessel, and that's the utility of the covered stent. And the so-called pave and crack technique, where you pave it first with a covered stent, and then you crack it and intentionally rupture the vessel so that it's covered and you're not going to have extravasation. And that's, actually Andre Schmidt and Dirk Scheiner published a paper on that technique. The other issue is it can be very painful for the patient when you intentionally rupture the vessel, so we usually do some kind of preemptive tumescent anesthetic. We don't use the bullfrog like they showed, but just going percutaneously to infiltrate lidocaine into the periadventitial space. And sometimes you actually have to oversize the covered stent because you're going to have to be able to balloon it enough to rupture it. If you put the covered stent in and can't rupture and open it up, then you got a problem. Then you may have an occlusion with your
So
with your
this
covered
is,
stent.
Darren, this is a 6.020 Dorado
And we are at 18.
18 atmospheres. We're going to go. Go to 20, please. So I think it's one of those things. You're either going to open it, or it's like I think Mike Backrack said this to me. Either you poop or you get off the pot. That kind of thing. Yeah, I mean.
Did he use
I don't
did
think
he
I
use the
ever
term
said
poop? I just want to know if the term poop was actually used.
So PK, you're a brave man because you're gonna potentially intentionally rupture this before you cover it.
That's kind of what I'm hoping not to do, Darren.
Actually, that's not what we're planning to do here.
So Darren, my question is, or even Brian and Lawrence and the panel, when you see a balloon inflation like that, is that adequate to place a Supera?
I don't think so. I think you want to resolve that whole waste.
Right, I agree.
And I'd say I would not necessarily go to a covered stent and do the paving crack, but what you do want to make sure is you're prepared to put a covered stent in there should you need it. If you crack these and rupture the SFA, the first thing you do is occlude it with balloon tamponade it, see if it seals. And if not, you got to have the right sheath size set up and right devices on the shelf to be able to open that up.
That's a lot better flow there, guys. I mean, I know it doesn't look pretty. Do you leave it with just a balloon angioplasty?
If there's not a big gradient, you might be better off just using a DCB here and getting out of Dodge. I think you're likely to have not a perfect result, but perfect might be the enemy of good.
And I think, Sahil, I think that's important to show everyone, right? Because, in this kind of lesion, I mean, putting an underdeployed Supera, as Andre and Dirk have shown us, it doesn't work well. I mean, or expand elongated Supera. So in this stage, that's the situation we're in. So, I mean, I think, at this stage, maybe I go with a 7.0 Dorado and try to expand it and then decide at that time. So give me a 7.0 100 Dorado, please. And we'll give it one more shot.
Yeah, the only other issue would be that the free wall, which is the compliant wall, just make sure it doesn't recoil to a great degree.
I think you have to look for recoil there. But even if you had some, I think you just use a bare metal stent if that were the case in a very focal fashion.
Yeah.
Would you go back with the Shockwave at this stage after having modified it?
I was going to ask that originally. Has anybody had experience of
Yeah,
failed and then
so,
return?
So sizing definitely matters, PK. So if you had a slightly undersized device, it may not work as well. So what I often will do is go up a size and then put that middle marker where you have the maximum energy and concentrate it there and just wail away at it. It takes a little bit of patience, but we've seen some good results.
Do you break the rules and go 6 as opposed to 4?
Yeah, no, we've been told by the engineers that it doesn't matter how much pressure you put in the balloon in terms of energy delivery. In fact, they argue that there's better energy delivery at 4 atmospheres.
Gotcha.
So we usually will go up to 4, but you have to make sure at nominal at 4, you're opposed to the vessel. Otherwise, the energy won't be dissipated properly.
This is so-called geographic miss, but for lithoplasty,
Yeah,
right?
right.
All right, so
We're all learning how to use this
We're
technology.
just going to tell you very quickly, we just decided
Okay.
what we're going to do is we're going to balloon this with a 7.0, and then we're going to deploy a 5.5 Supera. I think at this stage, if this doesn't rupture with a 7, it should have enough compliance to be, I see it's going very smoothly across it. It should have enough compliance for us to be able to deploy that Supera with minimal elongation, I hope. Negative?
So, PK, we're going to go and do a talk real
Yep,
quick.
please,
and
please.
We'll, don't try and rupture this while we're gone, okay? Okay. So, I'm going to ask.
You guys have encouraged PK to use the 7.0 here, so you guys have all made preparations to perf this vessel. So
Sahil, would you like to tell us
We
about...
just basically covered my whole talk.
Yeah, so,
I think Sahil, before you guys go, I think we got it open. So if you guys can see it.
Yeah, we saw it expand there.
How's the patient feeling?
Yeah,
not
he
good,
is,
not good.
So
I'd say you expanded that well enough. I'd think about going up to a 6.0 Supera.
Got it.
Yeah, 6.5 is probably better.
let's take a
Let's,
all right,
let's
so
see if you
we'll
perfed.
we'll go give a talk, and then we'll come back to you, okay?
Gotcha. Thank you. Got to say it's over
All
here.
right, Mike. So I think Dr. Backrack, I think PK went to the expert exchange.
Did we do Ivan?
Oh, okay.
The technical forum, but I'll just show you the pictures here
Okay,
we got
great.
after the 7.0
Thank you.
Dorado. So it looks like we were able to do it with a slight hematoma there. I think we broke the lesion, but there's a slight hematoma. But no perf. So we decided to go with a Supera, as you said, a 6.0 Supera. So I'm just deploying the 6.0 Supera. I think if you want to finish a talk and come back.
Why do you need
Get it
another one?
ready?
We have one.
All right. Well, no, actually, looks actually pretty good. What do people think? I mean, do you worry about
Okay,
that?
open another one quickly. Put it on the other.
There's clearly...
I think your angiographic result acutely will probably look good with a well-deployed Supera stent. The question about durability is certainly there. I think I wonder if an adjunctive drug-eluting technology would help with long-term patency. You generally get outward remodeling with DCD utilization. And I think that only time will tell, but it's hard to imagine getting away without a scaffold in some of these cases.
Well, yeah, and so here he's going ahead and deploying the Supera.
Pretty long segment,
Yeah, it's a
basically that
150. We
entire
took a
segment.
60150.
You're going to stack it there where the
Yeah,
residual
right
one-
where we had the recoil. I'm stacking it right where the distal calcification is.
And I think that's good, because I think if you stack a little extra there, you can come back with a
Yeah.
short balloon vocally
Yeah.
and try to iron it out
Yeah.
a little bit after the fact, because it
Yeah.
can be really hard to deploy these in the very bulky calcified lesion.
Yeah, the
one
plan
issue-
was to use a 7040 when we come back.
One of the foibles of Supera is, as you know, the post-dilatation is really a non-existent experience, right? I mean, it's the lumen is what it is, and that's why pre-dilatation is so important.
Yeah.
The elongation for success is less than 20%. That's when you talk about a
Should I go?
10 centimeter stent, that's a fair amount of territory that you can elongate.
Take a
Stack it
short balloon.
10 or 20%, then that
Yeah.
performs a hell of a lot better.
Right.
So here again, that's where our lesion is.
whatever
So
they
I'm
wanna
trying
do.
to stack it as much as possible. So I think I got it pretty okay.
Ready?
What do you
That looks
guys think?
great.
That looks like your prep is
That looks like
quite
a pretty good
adequate.
lumen, yeah.
Got the wire? Don't let the wire go.
I'm having a lot of resistance to stack it. So I think that's because
Right here, right?
the vessel itself and the calcium.
20.
I think I'm getting closer though.
How about right there?
But I thought 60 will have a hard time, but
We're in the
I think
aorta
it's
now.
not bad.
The lower, right? Yep. Okay, right there. Go.
Can you mag up?
We're ready.
A little bit of elongation here.
Guys, calm down. Let's do it right.
Just go low mag.
More?
Low mag more. Any thoughts on? I'm getting a lot of resistance with the elongation here. I think that's what we were expecting.
Yeah, some of that's the resistance up above with that sheath. But
Yeah.
Yeah, I mean, I think you're doing fine. You just have to go slow.
I have so much laxity in the lever. I think I came to the end of it. So I'll take a short balloon.
So
It's a
let's
7
measure against your ruler just to get a
Yeah.
sense.
Okay. Good.
This is a 6-150.
Yeah. So it's this is our lesion exactly. So I think we might have elongated a little bit. It's probably become like 160 or 170. So it covered the whole lesion.
7040.
But Lawrence is
40.
giving you 3 centimeters.
We can use that.
20%
I
margin.
can tell you in Superb, though, we had
740.
patients subjects who got enrolled who had a 12 centimeter stent and had 24 centimeters of stent deployed. So
7040.
it was,
Yeah, the patency rates for those are.
those were
pretty
abysmal,
low,
yeah.
so.
So
Give me
it
a
can
new.
happen, though.
740.
Give me a new balloon.
All right, you're going to show us a picture here?
Yeah.
Okay.
We'll just take it. I was going to post it, but I think we can do that. I think one spot where I'm going to hit it right where the elongation is. And on the top. What do you guys think?
Yeah, it looks pretty good.
Yeah.
Let's run
Looks
your
like-
pressure wire back down and see.
Is that a gradient?
The only time you can post-dilate or get any remodeling
Post.
would be now.
Yeah.
I wonder if going back in with shock wave maybe.
Oh, I'm sorry. I'm not able to hear.
We don't know.
Yeah, no, exactly.
And you can get a little remodeling or a little expansion at the ends, I've noticed, but
Yeah.
not so much in the middle of the stent, it seems.
All right,
Anything-
I tell you what, we're going to
Yes.
come back to you in just a minute, all right? And then what we'll do is,
Yeah, I'll post it by that time.
Okay, great.
Yes, and
All
then
right,
I
so,
think I can show you the final result.
there
Yeah,
you,
Dr.
yeah, you're
Backward.
on live.
Yeah, so we got the Supera. So this is a 150, 70150. So I took a 150 just to show the elongation. So it's almost, I think I got about 20 more, so I think I'm about 15%. So I'm pretty okay, less than 20%, I guess. So this is after the final 7.0, and I think I got a pretty good result. The IVUS did, looks like the IVUS is great. We got our lumen. Any thoughts, Dr. Backward?
Oh, it looks very good, actually.
I think,
I think that was actually a good choice, particularly, and it emphasized, I think, what you did from a vessel prep standpoint to allow that stent.
Yes.
But I think had you not done that and left that Superior stent incompletely deployed, it was destined to fail prematurely.
Any comments on the panel, or everybody thinks it's okay?
Strong work.
Yeah, it
From what
looks
you
very
started
good.
with, that
We
looks
should give him a
fantastic.
hand.
Thank you, guys. Thank you so much. Really appreciate it. Thank you.